Hi, I'm Elaine Balan, and today my groupmates and I are going to talk about the physical and chemical injuries. The first thing I will be talking about is the attrition. Attrition is the mechanical wear of the incisal or occlusal surface as a result of functional or parafunctional movements of the mandible. Attrition happens when bruxism tooth-to-tooth friction during deglutition and clenching. Treatment may require the wearing of a bite guard during sleep. Next is the erosion. Erosion is the microstructural loss of tooth structure in areas of stress concentration. Heavy essential occlusal forces leading to tooth flexure and formation of microfractures. And to prevent enamel loss and keep teeth healthy, be sure to brush and floss teeth daily and eliminate highly acidic foods and drinks from your diet, such as carbonated drinks, lemons, and other citrus foods and juices. Rinse your mouth immediately with clear water after eating acidic foods or drinking acidic drinks. Next is use a straw when you drink acidic drinks. The straw pushes the liquid to the back of your mouth, avoiding the teeth. Next, monitor snacks. Snacking throughout the day increases the chance of tooth decay. The mouth is acidic for a few hours after eating foods high in sugar and starches. Avoid snacking unless you're able to rinse or brush teeth. Chew sugar-free gums between meals. Chewing after meals also helps stimulate the flow of saliva, which washes acids off of your teeth and protects the enamel constantly during the day. Drink more water throughout the day, especially if your mouth is dry. Use um, fluoride toothpaste. And the treatment of tooth enamel loss depends on the problem. Once the enamel of a tooth is lost, it cannot be replaced naturally. With a strict remineralization, tooth enamel loss may be limited and no further treatment will be required. Sensitive toothpaste may be used to manage any discomfort. And for abrasion, abrasion is an abnormal tooth surface loss resulting from direct friction to forces between teeth and external objects. Improper toothbrushing, detrimental oral habits, improper use of dental floss and toothpicks. And it is important to use the proper toothbrushing technique. Choosing a toothbrush with softer bristles, dental plaque is soft and requires no more pressure to remove than wiping the surface with a soft cloth. Because of the many contours and crevices of the tooth, we use bristles in order to help us reach surface of heavy tooth, but they shouldn't be any harder than necessary. When brushing, we should with small amounts in circular motions rather than straight side to side or up and down motions, making sure to apply just enough pressure to gently clean the teeth.
Crown crease or crack enamel infraction. Crack or incomplete fracture of the enamel without loss of structure. No treatment. Seal with the cracks with flowable composite. Prognosis is good. Crack or crease lines can occasionally be observed during routine examination. Next one is crown fracture. May involve enamel, dentine, and pulp. Horizontal may be vertical or oblique. Pain associated with dentine exposure. The diagnoses are rough edge of the tooth, sensitivity to air, hot, and cold substances. Lip bruise or laceration is seen commonly. The treatment depends on the extent of the fracture. Prognosis is range within 80%. Crown root fracture. Fracture involves enamel, dentine, and cementing. It may or may not involve pulp. Treatment depends on location of fracture. Next one is root fracture. May involve apical, middle or cervical third. Maybe horizontal or vertical. The best Prognosis for this case is apical. Medial and apical repositioning if mobile and firm. Immobilization for 2 to 3 months. The internal resorption. Pathophysiology are resorption of root surfaces, whether internal or external, occurs by the action of plastic cells. These are the multinucleated giant cells with cytoplasmic vacuoles originating from blood-borne leukocytes from the bone marrow. The precursor cell is from the monocyte cell line. The cellular components in a resorptive complex includes the clast cells, which has odontoclasts, dentinoclasts, osteoclasts, cement and cementoclasts, monocytes, and macrophages. Clinical features often an incidental finding and presents with no symptoms. If symptoms presents or it will be similar to pulpitis, lingering pain after stimulus, for example, sugar or cold, persistent pain due to pressure. The treatment for this case are removal of all soft tissues from the site of resorption, endodontic treatment before perforation in internal resorption, placement of calcium hydroxide paste for mineralization, surgical exposure, and restoration. You can also use extraction if structure of the tooth is compromised and prognosis is poor. Root canal therapy, due to destruction of internal anatomy, debridement with instrumentation alone is inadequate.
Hi, I'm Patrick, and I'm here to talk to you about ankylosis. Tooth ankylosis is the fusion between the tooth and the bone. It is an uncommon phenomenon in the deciduous dentition and even more rare in the permanent dentition. Actually, it is uncommon sequela, and the cause for this sporadic happening is unknown. Ankylosis does occur rather frequently after a traumatic injury to a tooth, particularly occlusal trauma, but it can be also seen as a result of periapical inflammation subsequent to pulp infection. Periapical inflammation is a well-recognized cause for root resorption. Ankylosis sometimes also follows root canal therapy if the periapical ligament is irritated or seriously damaged. Tooth ankylosis is not likely to be of random or accidental in origin, nor is excessive or traumatic pressure a problematic cause. Although the latter enjoys wide acceptance as a possible explanation, tooth ankylosis may be due to disturbed metabolism. The clinical features of tooth ankylosis is the seldom manifestation of clinical symptoms unless there is uh, concomitant pulp infection, which may be the underlying cause. If there is an extensive area of root surface involved, the tooth may give a dull, muffled sound on percussion rather than the normal sharp sound. Uh, may become apparent only at the time of extraction of the tooth when considerable difficulty will be encountered. Sometimes surgical removal may be required. And some uh, radiograph feature, if the area of the ankylosis of a sufficient size, it may be visible in the radiograph. However, if there are loss of normal thin radiolucent line surrounding the tooth, it represents the periodontal ligament with a mild sclerosis of the bone and apparent blending of the bone to the tooth root. Treatment depends upon whether the ankylosed tooth is deciduous or permanent. The time of onset, the time of diagnosis, and the location of the affected tooth is also a factor. If the ankylosed tooth is deciduous and has a successor, the general rule is to extract immediately and, if necessary, to insert an appropriate space maintainer. If the tooth is deciduous and without a successor or successive succession teeth, and the onset is early so that submergence is threatened, treatment involves extraction and space maintenance. If the tooth is deciduous and without a successor, and the onset is late, proximal and occlusal contact may be built up at maturity. And if the ankylosed teeth or tooth is permanent and the onset is early, the tooth should be luxated. If repeated luxation proves ineffective, the tooth should be extracted. It should not be permitted to submerge. And if the onset of the ankylosis is late, the permanent tooth should be luxated. If the attempt is unsuccessful and the tooth does not submerge, treatment depends upon whether the ankylosed tooth is deciduous or permanent. The time of onset, the time of diagnosis, and the location of the affected tooth are factors. Example, if the ankylosed tooth is deciduous and has a successor, the general rule is to extract immediately and, if necessary, to insert an appropriate space maintainer. Uh, and another one is if the tooth is deciduous and without a successor, and the onset is early so that submergence is threatened, treatment involves extraction and space maintainer. Thirdly, if the tooth is deciduous and without a successor and the onset is late, proximal and occlusal contacts may be built up at maturity. Fourth, if the ankylosed tooth is permanent and the onset is early, the tooth should be luxated. If repeated luxation uh, proves ineffective, the tooth should be extracted and it should not be permitted to submerge. Uh, Another one example is if the onset of ankylosis is late, the permanent tooth should be luxated. If the attempt is unsuccessful and the tooth does not submerge, it may be built up at maturity. And lastly, a deeply submerged ankylosed tooth, deciduous or permanent, should be left undisturbed unless it is infected or constitutes an immediate or potential threat to the occlusion of the patient. Uh, Another topic I want to discuss is the denture-related injuries. The oral mucosa is subjected to a variety of injuries as a result of wearing of artificial dentures. These may be manifested uh, specifically as inflammatory fibrous hyperplasia and inflammatory hyperplasia. And the inflammatory fibrous hyperplasia injury may consist of tumor denture epulis, and it is a single or multiple uh, fold or folds of hyperplastic tissue in the alveolar vestibule. Mm, uh, Epulis fusaratum or inflammatory fibrous hyperplasia is a tumor-like hyperplasia, fibrous connective tissue that develops in association with the phalange of an ill-fitting complete or partial denture. Although the simple term epulis sometimes issued cynomalus for Epulis fusaratum, Epulis is actually a generic term that can be applied to any tumor of the gingiva or alveolar mucosa. Uh, And treatment of the Epilis fusaratum, or fibroepithelial polyp, is surgical removal with microscopic examination of the excised tissue, and treatment of the Epilis fusaratum or the polyp consists of surgical removal with microscopic examination of the excised tissue also. Ill-fitting denture should be remade or refined to prevent a recurrence of the lesion that is causing the injury. Inflammatory papillary hyperplasia uh, is a reactive tissue growth that usually, although not always, develops beneath a denture. Although the exact pathogenesis is unknown, the condition most often appears to be related to the following: an ill-fitting denture, a poor denture hygiene, and wearing the denture more than 24 hours a day. And uh, the it develops on the edentulous mandibular alveolar ridge or on the surface of an epilis fusaratum. It is asymptomatic. Mucosa is erythematous and has a pebbly or papillary surface.